Hello, everyone. My name is Arya,
And I'm Josiah.
and we're back for another Cases of the Week this week. This week we'll be kind of focusing on MSK. So let's go ahead and dive right into it. This is our first case of the day. So you have this patient here. They fell on their outstretched hand, and they have pain in their left wrist now. So now they're coming to the emergency department. So first thing you want to do that they did is they got an X-ray. No prior imaging of the hand there. And I'll just give you a second just to kind of look at it. Pause the video. I know, and we'll dive into the anatomy a bit. Alrighty. All right, so the carpal bones. I know it's a bit complicated, but we'll get into some methods to make it easier. But just kind of looking at the bones, we have the radius here, which is the bigger bone, and then you have the ulna as well. And then here are the kind of the carpal bones of the wrist. So this big one right here is your scaphoid. Then you have your lunate right here. Then you have your triquetrum, and then you have your pisiform, and then right here you have your hamate bone, and then your capitate. Then your trapezoid will be right there, and then your trapezium will be kind of more further anterior on the wrist bone. So I know that's a lot. That's a lot of different carpal bones on the wrist to think about. And we'll get into a way to make it easier. But just looking at that, what's based on kind of similarly at radiographs we've talked before, just take a moment to think what's wrong with these bones? What looks a bit different? And yeah, you're right. So this right here is going to be a little fracture here of the scaphoid bone. You see that little line is kind of going all the way through. And this is a pretty big thing you don't want to miss. MSK radiologists always look out for this because this can have a lot of consequences and it can cause a lot of long-term complications for patients. So a scaphoid fracture is it's a big deal, and it's really big on boards as well too, as we'll talk about. All right, so getting into how to remember all those bones, because I know there's a bunch, and there's going to be a lot of mnemonics online as well too, so you can go ahead, feel free to read up on those. But the one we like to use is so long to pinky, here comes the thumb. So when you're looking at that, we use the S and so to be the scaphoid, L being the lunate, the T and 2 being the triquetrum, the P being the pisiform, H being the hamate, the C being the capitate, T being the trapezoid, and T being the trapezium. And so it comes like in this order. So this is the scaphoid right here. So this is the S, then the lunate, then the triquetrum, then the pisiform, and then the hamate right there, then the capitate, then the trapezoid right here, and then the trapezium. And so that's just a good way to kind of like remember the order of things. So definitely one worth to remember for anatomy classes and all that stuff. So what in the end, what was it? If we look back at that, it was a scaphoid fracture. And typically the mechanism will be like, you'll see a patient, they fell on their outstretched hand, they fell while biking, and, while bracing, they fell on their hand or wrist. And, typically they present to the ED, and the treatments usually you want to definitely immobilize or do surgical management, depending how stable or unstable that fracture is. And the reason for that is there's a lot of complications associated with it. The most common ones you'll see on boards and even in real life is something called a vascular necrosis. You may have heard of it across your studies. That's just literally like the bone dying, essentially. There's no blood flow. The blood flow is compromised from the fracture, and yeah, essentially the bone tissue is dying, and that can lead to a lot of bad stuff. The other thing is called non-union, which means the bone is just failing to heal from the fracture, so that bone is not going to recover. And so I would definitely remember this because it comes up a lot in med school, on your third year shelf exams and on step 2 as well. It's a very high yield topic that the NBMEs like to test you on. So a lot of times when we took our shelves in step 2, when they're presenting a scenario where a patient fell on their wrist, they have like pain in their hand and stuff, and they get an x-ray. A lot of the times if you just see them showing some of those carpal bones, there's a high probability it's probably going to be a scaphoid fracture on your exams. Some are harder to see. The one we chose was a very clear one, but if you come across this, kind of that image with a similar clinical scenario, it's a very good probability and safe choice to pick scaphoid.
All right, let's hop into case 2. Hopefully this one's a little bit more simple than the complicated carpal bones, but still something that's definitely going to be high yield. So this indication, the patient came into the emergency department complaining of pain and weakness in their left forearm. So the study ordered was a forearm series, and that's just another term for an X-ray. It's going to be an anterior posterior or an AP view of the forearm as well as a lateral view. So we see both of those, and there's no prior imaging for this patient here. So take a minute if you would like and try and spot the abnormality if you can, and then we'll discuss the anatomy. All right, so first I'm just showing a normal AP or anterior posterior view. Not going to label all the carpal bones because we're just focusing on the forearm, and we have the ulna and the radius labeled here. And then next let's show our patient's forearm. So if you were able to spot the abnormality, you should see that, again, there's a fracture here, and this fracture is in the radius, and that's near the top of the radius or that styloid process close to the carpal bones. And then here's just a blown up image if you weren't able to see it as well. So it looks like there's a complete fracture in that radius bone that just cuts straight across. Now let's check out the lateral view. So in the lateral view, again, we're starting off with a normal image, and pretty much the radius and the ulna from the lateral view are almost superimposed on top of each other. It's hard to really tell them apart. But as we see in our patient's image, you can definitely see that there's this step off here. You can see there's a separation from the radius and the ulna. And I think it's almost easier to spot this fracture from the lateral view than from the AP view even. So again, we're just highlighting the fracture, and then as opposed to our normal lateral view, the radius and ulna, you can't really tell there's a distinguishing factor between them. So this is a special type of fracture, and this deformity is called the dinner fork deformity. It's hard to really tell in this image, but definitely, again, something that comes up on board exams as well. And a lot of the times, depending on how the patient's risk is, it'll sort of resemble a dinner fork, hence it being called a Colles fracture or the dinner fork deformity. Again, similar to our scaphoid fracture, the mechanism of action is almost always a fall on outstretched hands, usually with the wrist extended and dorsiflexed. And then again, that management initially is going to be immobilization, sometimes with a splint, you'll do pain control, and then definitive management can be with orthopedic surgery. And this will all depend on the severity of your fracture. Complications are similar to a scaphoid fracture. You can have malunion, and then that's just another term for when the bones heal in an abnormal in an abnormal way and cause some sort of a deformity. There's also another fun one, complex regional pain syndrome. So that's more of a neuropathic condition, and it's kind of like the name suggests, where you'll just have this neuropathic pain that persists even after the injury has healed. And then we also have a very rare complication of compartment syndrome. And that's sort of a more serious complication when you have bleeding into a fascial compartment as a result of the severity or a severe fracture. So similar to a scaphoid fracture, I'd say it's a little bit less high yield, but definitely still important and a little fun to remember that dinner fork deformity. All right.
All right, well, these are just our references. We hope you enjoy these quick little cases, and we keep on hoping to do it. And I know for a lot of third years, this year's just started, shelves coming up, so we hope to do more of these and also maybe do some high yield step 2 and like shelf images radiographically in the future. So yeah, look forward to that, and we hope you all have a great rest of your week. Take care.